Well, hello everyone, and welcome to today's webinar from the AI Nurses Network. We've got a great nursing colleague with us today, Meghan Turchioe from Columbia University School of Nursing, who's going to talk about AI in her research. Over to you, Meghan.
Hey, wonderful. Well, thank you so much for inviting me. I'm really so delighted to be here. I wanted to just give a little bit of a sampler of how we're using AI in our research at Columbia School of Nursing. I'm going to talk about a couple of different projects that are research-based, as well as some work we're doing to try to build up nursing capacity for AI and sort of AI competencies. I would love to talk more about that too. So the first sort of small project I'll mention is very patient facing. So this is work I've basically been doing since I was a PhD student, supporting patients who have chronic diseases to better self-manage their chronic illness. And lately, as we're seeing greater capabilities with AI, that work has shifted into being more kind of AI-based conversational agents. So I'll talk a bit about where we're at with that. I also wanted to talk about a project that's a little bit different, not patient-facing, but actually applying large language models to clinical notes to help us understand patient experiences and symptoms. And then the third is, as I mentioned, talking about AI capacity in nursing and nursing research. So just a bit about me. So I started my career as a cardiac nurse at NYU. And while I was there, I was working nights on a cardiac unit and taking care of patients who were really bombarded with so much information and then sent home in a very short amount of time. And they didn't have enough time to really be absorbing the information they were being told or understanding and building skills around self-management to be able to prevent coming back to the hospital. And I felt like there was this huge opportunity to use informatics solutions, which now I think AI has sort of subsumed that term, to be able to actually help them to better self-manage and stay out of the hospital. And at the same time, as I was working as a nurse, I was also noticing that there were a lot of new technologies being rolled out. I actually started my position a couple of months before a large electronic health record vendor was rolled out. We moved from paper-based charting to digital charting, and I watched how that totally changed nursing practice and sort of the gaps in knowledge and ability that we had as bedside nurses. And that's always been an interest of mine as well. And so that sort of stayed with me as I did my PhD actually at Columbia. I did a postdoc in informatics in the School of Medicine at Cornell, and then came back to Columbia 4 years ago as an assistant professor. And I lead research that's focused on AI across the continuum of patient care, mining clinical text and research training for our mentees and students. So the first project I'll just talk for a minute about, because this is really very early stage, is conversational AI for patient self-management, or sometimes we call them chatbots. And this is chatbots that meet patients where they are to help them manage their health. So as we've probably seen, there have been some high-profile articles about how basically everybody is turning to ChatGPT now for medical advice. And I think there's a real reason why people are doing that. It's a very intuitive, simple interface, and it's an easy way to ask the questions that are on your mind and get a very easy to understand response back. And we know that doctors and nurses and the entire care team just simply don't have enough time to provide the tailored guidance that patients need. Managing health and preventing chronic disease is a 24/7 job, and there's just not enough time in the day. We try to provide, of course, patient education when we meet with our patients. We try to provide written materials, but often there's a certain level of sort of, it's templated, it's a bit generic. It doesn't actually fit specifically to the patient's unique context and the questions that they may have. There's also, for most health management, a level of behavior change or behavior management that's sort of required. And that sort of requires this ongoing dialogue to be able to understand what decisions people should be making in their day-to-day lives, like what should I have for lunch, and is it safe for me to go for a walk in the heat, and things like that. So what we've done is we are starting to prototype an LLM-based conversational agent. And one of the things we're really interested in doing is actually developing this base architecture that can be used for a number of different chronic conditions that patients may be wondering about. And the goal is not for one patient to come here and see sort of a bunch of different things, but actually for this to be a research resource for researchers who want to create a very tailored chatbot for their particular patient population so that they don't need to start from scratch. So I'm just going to play a few seconds of the video here. This is kind of a recording of what the screen might look like. This is for heart failure. You can actually load in a knowledge base that uses what's called a RAG, retrieval augmented generation based approach to constrain the responses based on some validated sources, not anything on the internet. And here's another one we're developing for cardiovascular disease risk reduction, and another one for people who have insomnia, particularly related to a past history of trauma. And so there are well-vetted protocols for cognitive behavioral therapy for insomnia, and we're working on advancing some of that work for the app. And again, for all of these, you can actually just put in, the researcher can load whatever resources they want the chatbot to draw from. I think two caveats that I would add, because one of the questions that we always get with all of this is, well, we don't want AI to be replacing nurses or healthcare professionals, and I would completely agree. The goal of this is not to be replacing a healthcare professional. It's rather saying healthcare professionals are too few and far between to be providing this resource and support that patients need in their day-to-day lives. Can this work extend what nurses, community health workers, and others are doing in partnership with them? The other point I'd like to make is that we certainly don't envision a tool like this just being quickly kind of coded for whatever disease you want to focus on and then deployed in the world. We definitely would advocate for there to be a large amount of user-centered design, engaging with end users to understand their needs and preferences, tailoring interfaces and content based on that, and then a lot of validation and testing. We've started to do some validation and testing with the heart failure app with a series of cardiology experts. And eventually we're planning to test all of these with not only experts, but patients as well. And we would certainly want anybody who eventually uses this tool to do the same. But we are planning to make this open source so that anybody can kind of go in and use it. As I said, the co-design is very important, and part of what we do in the co-design is pay very close attention to health equity. So I think in our previous work, as I said, most of my research has been on supporting patients in self-management, and we've always tested if we're giving them information or if we're giving them a data visualization that shows them a test result. Can people who have different literacy levels or different numeracy levels still understand this? Making sure that the information is accessible to everybody. So as I said, the clinician handoff with the human clinician will be really important because we're not envisioning this as a standalone AI intervention, but something that works in conjunction and partnership with a care team that we feel is still really essential. We plan to evaluate not only preferences, do people like or not like this, but have they actually been successful in enacting the behavior change that we actually want them to? And we'll hopefully do that in some future clinical trials. And we envision this being, several iterations before we have anything close to a final product, because this is all still very new. And we're still figuring out, for example, if an intervention has multiple components, which components are appropriate to have the AI support and which ones do people really still want their nurse or therapist or community health worker to be doing with them live. Okay, I'm going to transition now to the second project, which is not patient-facing, but actually studying patients from the clinical documentation that we have about them. And this is a project that we call Mind AF. So it's focused on atrial fibrillation, which is what a lot of my research focuses on. So this is a very common cardiac arrhythmia. In the US alone, about 10% of older adults age 65 and older have atrial fibrillation, and lifetime risk for AFib is between 1 in 3 to 1 in 5. The incremental cost is also quite expensive because we see that many patients have to go to the emergency room or be hospitalized to treat the AFib, which often comes back frequently despite being treated. Another aspect of AFib that's quite concerning but has gotten a lot less attention is the fact that it significantly raises the risk of dementia. So even in stroke-free cohorts, we see that about 40 to 50% of patients have eventually go on to develop either mild cognitive impairment or dementia. And this is because, of course, one of the main mechanisms is AFib-related stroke or cardioembolic event. But there are many other reasons why people may actually have cognitive decline, and they can relate to hypoperfusion, inflammation, and even microbleeds from being anticoagulated as part of the AFib treatment. But a major focus area for us is the fact that basic science studies have shown that when brain injury occurs in the context of AFib, it's often pretty early in the disease trajectory. And so it's important for us to be identifying people early who are starting to show the first signs of cognitive decline. Right now, cardiology practices have no time to be screening for cognitive impairment, and they don't feel that they're equipped with the tools to be doing that. And so we're looking for an easy way to identify people who may be at risk and may need additional support that doesn't require manual screening of all patients in cardiology practices, which is likely unrealistic considering how time and resource constrained they are. And as I said, this is something that often goes undetected. There was some attention to this a couple of years ago with this international consensus report calling for more attention to this. I was very intrigued by a colleague who now is a partner on this research. She published some work in JAMA Open in 2021, I believe, that showed that you can actually identify reports of confusion, memory loss, and disorientation in the clinical notes long before a formal diagnosis of dementia or mild cognitive impairment is made. And these often show up as things like the doctor or nurse practitioner writing, "She's a little forgetful," or "the patient required frequent cues and reorientation during the exam." So these can be very subtle signs that there is something going on, but a clinician would read this and immediately know this is a person who may be having some cognitive concerns. And sometimes it's also very overt, like subjective cognitive concerns, or we are even finding cases as we're going through the notes of patients taking dementia medication, but not having any formal diagnosis of dementia in the chart. And so there is a hint that something is going on. Probably they expressed at some point a concern, or maybe they were in fact diagnosed, but for some reason there is no billing code associated with that. The billing codes can be problematic for a number of reasons. So looking in the notes sometimes gives you a different view. And so by using broadly what we call natural language processing, which is what's shown in this figure here, where there's some conversation that happens and it gets documented in notes. And then we can use the natural language processing approaches to mine the free text notes and convert it into some structured quantitative format. And then once you have a data set that looks like this, you can then do some analyses to understand prevalence rates or predictors and downstream outcomes. So we've been doing this work for a while. It started with using natural language processing to understand the symptoms of AFib itself. But now more and more, we're seeing that large language models are capable of far outpacing what our previous methods of using natural language processing were able to achieve, and they're way faster. So we're using large language models to extract generally what we call subjective cognitive decline, but we're not sticking to a tight definition of that. We really mean any mention of cognitive concerns that the patient may have. We're bringing together the structured data from our clinical data warehouse that can include demographics, diagnoses, medications, together with the unstructured notes. And then we're filtering that down based on eligibility, and particularly we're interested in people who don't have dementia before they have AFib, but rather develop it at some later time point, and trying to understand the clinical course for patients who have AFib and later develop dementia. So, as I said, we're using a loose definition, and part of what we do in the natural language processing steps, especially for symptom mining, you can't necessarily rely on things like the UMLS or other structured vocabularies because the symptoms are not very well represented in the UMLS. And so usually the first step is we have to actually create our own taxonomy of symptoms and synonyms that might represent those concepts of interest. And so we identified 6 neurocognitive domains that we were interested in mapping. And we developed a number of synonyms using both by looking at the clinical notes as well as expert feedback. We have a team of cardiologists and neuropsychologists and neurologists who are able to provide this feedback. And as I said, we're also tagging if we see dementia medications mentioned in the notes, because that is sort of a hint that something is happening. And so we're hoping to kind of cast a broad net and then be able to drill down on each of these specific domains. So the next step when we do natural language processing is to be able to say how effectively your NLP pipeline is working against what we call a gold standard. And the gold standard is something that you create from a set of experts who look at the notes and say, yes, indeed, this person has subjective cognitive decline or some type of cognitive concern. And what is the domain that it falls in? Is it learning and memory? Is it something else? And so we had 3 independent reviewers. This is actually quite similar to qualitative research. If anybody's ever done qualitative research, it's a very similar approach. You sort of divvy up the notes and have people independently review them and apply their coding to it. And then later you reconcile any disagreements and you kind of come up with your gold standard reference set. And that's what you compare what your LLM output to be able to say how well it performed. Now, even just using large language models in itself, as I said, they're a lot faster and more capable, but then you have this added question, which we didn't have before, of how you actually prompt the LLM to extract the concepts of interest. And we've tried a few different prompting approaches. So the first one is what we call zero shot. So this was essentially just some very general instructions on the types of concepts that we were interested in and the examples. So we did give it the taxonomy and we told it how we wanted it to extract the information, save it in a structured format, but we didn't give any specific examples. It was more general instructions. In FewShot, we gave 5 representative examples. So what this meant was we would write a generic sentence and then explain how it would be coded. And we kind of repeated that across domains. In FewShot, with challenging cases, we kept the representative examples, but we also taught the LLM based on what it got wrong in approach 2. So we took everything it misclassified in approach 2 and gave it sort of the answers to the test and said, here's how you should have classified that. Now, I think it would stand to reason that you would expect for the third approach to perform the best because you gave it the answers to the test. But interestingly, I'm just going to jump ahead. We didn't find that. So here you see that the zero shot is in blue, the few shot is in orange, and the green is the few shot with hard cases. And the few shot with hard cases actually performed a little bit worse than just few shot. And we aren't quite sure why this was. We're kind of doing some detective work to try to understand why. But one of the theories that we have is that we've noticed that when you give too many instructions to large language models, they perform worse. They're not able to apply sort of flexible reasoning and understand across a range of contexts what we might be interested in. So by providing too many examples, we almost were overly constraining its ability to identify the easy cases. That's our working theory, but of course we're still sort of digging into this. So we're excited for where this will go because we hope eventually that this could be some type of clinical decision support tool that can surface these early cognitive concerns that busy clinicians don't have time to read every last note that's in the chart, and they may miss that this is a person who has cognitive concerns. And that's important not only for potentially being able to screen and refer patients for dementia care as appropriate, but also because even in the context of cardiology, you want to make sure that the patients are well supported, that if they're completing an informed consent about a procedure, that there's somebody there to help them. I think it's important information for a range of specialties. Okay, the last thing I'll briefly touch on is just how we're building AI capacity in our nursing field. So AI literacy has been a very hot topic, obviously, in nursing. And, Dr. O'Connor, you've been a leading voice in that. And so we're really interested in this. And it started even when we noticed ChatGPT's rapid adoption in November 2022. And these statistics still kind of continue to stagger me that in late November of 2022, GPT was first launched, and within a week, they had 1 million users. And within a month, they had 100 million users. And it really sort of completely changed the landscape of what we call AI. I think that, AI really, when you look at what it is, it's not particularly new. The foundations of it have been around for decades and decades, and certainly in the informatics world, a lot of the methods and the models are building on what we've been using. But it's thrust this idea of AI into the common narrative, and certainly for healthcare, it has made healthcare leaders sit up and say, "Oh, we want to have AI. We want to have AI." So now we have to say, from the position of a nursing school, how do we prepare our nurses for this AI-enriched care setting that they're going to be entering? And this is really a gap for us because we see that a lot of our faculty have not necessarily gotten a lot of informatics training. And so are they necessarily ready to be teaching the next generation on AI? We sort of are thinking about how do we teach the faculty and the students at the same time. I'll just briefly talk about something we did a few years ago now, so it's a bit outdated, but in our PhD level class that we have for all of our nursing PhD students, and it's a required class for them, we teach them about data science principles, data visualization, and we thought this was an ideal place. This is the class that I teach at Columbia Nursing, and we thought it was an ideal place for us to be starting to introduce them and acculturate them to AI. Nurse PhDs will go on to be not just academic researchers, but leaders really in the field, and it's important that they're familiar with these concepts. We got a little bit of internal funding, just a few $1,000s from our Center for Teaching and Learning to be able to provide subscriptions for the students and allow them to attend some guest lectures, which was nice. And we focused on two things. We focused on just building generative AI competency in general, and this included some lectures from experts on how generative AI is and may be used soon in clinical settings, and just building awareness and ability to critique what is generative AI good at and what is it bad at. And that answer changes almost on a daily basis as the models continue to update and competition between the major models continues. But our goal was not to say this model is better than that, but to give the students the skills to critique for themselves. If they were to encounter a new model, how do you think through what this is good at and what this is not good at? The other thing was a bit more pragmatic. As I said, it's a data science class, and we have students entering from a range of backgrounds. Some of them have been doing machine learning for years. Some of them have barely loaded a data set into R. And that's okay, because that we don't expect them to be machine learning experts in the class, but we do, practically speaking, need ways of getting all the students on a level playing field so that we can all work together in our labs. So we saw this opportunity to use ChatGPT at the time, and now there are some very specific coding tools for this. But at the time, just ChatGPT for programming support. And we had the students actually alternate which weeks they used ChatGPT for coding support in the lab and which ones they did not. They were allowed to use all other resources, just not ChatGPT. And we did an evaluation of the weeks that they used ChatGPT versus the weeks they didn't. So in the general generative AI module, we did find that just simply giving the students some basic education and then an exercise to have them critique generative AI for different use cases like clinical decision support, patient decision support, and scientific communication built their ability to assess and critique generative AI, which was the goal. And then the second aim, we found that ChatGPT, interestingly, was helpful for some, but not all. So it was helpful in saving time for the people who were very brand new to data science and programming, but the advanced beginners or proficient students really didn't have a time savings, and there was no major difference in confidence. Although some of the most proficient students felt like having the double check with ChatGPT, interestingly, built their confidence a little bit more, but not necessarily for the novice or beginner students. So this was kind of used as like a first step, they told us, but they did usually verify ChatGPT's code with some other source. Okay. And so we kind of concluded that the hands-on practice was really important to help the students build their own judgment. When it comes to coding support, in this class, we've continued to use at the time, ChatGPT, and now this semester we're actually using Codex because, as I said, there are some very specific tools to generate code, and those are better generally than copy pasting into a general purpose AI tool. And it's a tool in the toolbox, but it's not the only thing. And certainly we continue on a daily basis to find errors. And so the students still need to know what they're looking at to be able to critique what the code that they're being given. Okay, the last thing that I'll mention is we're really excited about this next step. So myself and another faculty member at the School of Nursing, whose name is Natalie Paslinski, she's the Dean of Simulation, and she runs our Simulation Center. And she and I both applied for and were gratefully accepted into a higher education fellowship that Google is running for AI. And this is really just beginning. We just had our first kickoff meeting last month. But what they're really looking to do is kind of build community across higher education, not just healthcare, not just nursing, but for all faculty who are trying to use AI in the classroom and in research, building community, supporting competency. The project that I'm really interested in is this question of how we can build AI competency and informatics competency more in our pre-licensure nurses before they enter the workforce. And we're starting to explore how we might do that. I think there's the potential to use some of Google's products like Notebook LM, which can create mini podcasts from some products and interactive modules that students can do a quick interaction with. And the quick is really important because they have very little time. All of our programs are accelerated and students are completely crammed with courses and clinicals and deadlines, and they don't have a lot of extra time for, definitely not an additional class, and honestly, even extra lectures is difficult. So can we embed micro learnings and thread them throughout the curriculum so that they're getting this content where it's clinically relevant rather than it being a standalone thing? And we're also excited about how we could use that in the Sim Center, because that's very much replicating the world they're going to see when they go into the clinical setting. And I think there's the potential to build in some of these competencies as they're working through clinical scenarios and simulation. So more to come on this. We're excited, but it's very early days, and I'm excited to kind of keep you all posted. So with that, I just want to thank you again. It was an honor to be with you today, and happy to chat a little bit more about anything we talked about.
Oh, that's great, Megan. Thanks. You sound like a very busy person with all this work today.
Pretty busy.
Yeah. Great. I know you kind of touched on this at the beginning, but I guess as a nurse, how did you start become interested in AI? Was it just because it was out in the media and you kind of heard about it and you were a bit more curious?
Yeah, it's a great question. So I actually am going to trace this back to informatics. So when I was first coming to my PhD program in nursing, I was really interested, as I said, in supporting people who had chronic conditions and didn't have a great way of managing them. And I was completely unfamiliar and totally naive about what informatics was. And I think I had preconceived notions of informatics that were very outdated and inaccurate. I thought it was like outdated technology, and when I started meeting with mentors who were informatics experts, and they explained to me, no, it's about, at that time using wearables to track, symptoms and weight and biometrics and things. Um, and they explained the relevance with today's technology to being able to support patients. I immediately thought it was incredible, and that became kind of my focus area. The conversation about AI, as I said, really builds on the informatics foundation for me, and I think for the field. And so, as the term has shifted from informatics, at a time data science was the buzzword. I think AI is kind of the buzzword now. The work in some ways hasn't changed. It's just what we call it.
Yeah, I agree. And I guess for nurses who don't know anything about this, would you have any advice for how they might get started in their AI journey?
Yes, absolutely. So there are a number of free resources online which are excellent to take advantage of. Some of the ways that I like to stay in touch as well. Honestly, LinkedIn is LinkedIn feeds are a wealth of information and knowledge. And the nice thing is that it's not just kind of curated um, education. It's actually, you can see the discourse, because you can see somebody posting an opinion, and then you can see people replying and saying, I disagree for this reason. And I learned a lot from just seeing what some of the major voices have to say about various ideas. And sometimes people post controversial topics. It gets more posts. It goes viral. So you sometimes do get more, unfiltered opinions there. And then something that I've done basically since I was a PhD student is tried to get training and exposure outside of nursing. So I attended lab meetings in our biomedical informatics department, and then I did a postdoc. That's obviously very specific for PhD nurses, but I did a postdoc in a school of medicine in informatics. And it's not to say you can't learn a lot within nursing, because certainly there are so many nurses that are leading in this space. But I just think that there are a lot of lessons learned that exceed any particular domain. And so I try to think of it as domain agnostic, and just learn wherever I can and from whomever I can.
Yeah, definitely. And your Google Fellowship, I'm sure, will open up lots more avenues of learning for
Yes,
different
I hope
products.
so. Yeah.
Great. My last question's a really tricky one, but where do you think AI might go in the future, and what sort of trends should nurses keep an eye on?
Yeah, this is always a hard one to answer,
Mm,
because you need a bit of a crystal ball, but I'll pull out my crystal ball and do my best. So I think we're sort of at an interesting inflection point with AI in the markets, like in industry, where I think we saw a lot of hype and a lot of investment in AI. And now the questions are, where's the return on investment? Where are we seeing actual improvements, and what has been sort of just hype and fluff and hasn't really materialized? And I think in healthcare, we may see a little bit of a tempering of enthusiasm as well. Not that there can't be some huge wins. I think ambient AI has completely taken my breath away in terms of how quickly it has been adopted, and how widespread that use is, certainly across a number of different health systems in the US. And not saying that it's everywhere, but that I think the adoption has outpaced anything we've ever seen in terms of other informatics and AI types of tools. So I think I guess what I hope to see is that the real clinical benefit for nurses and doctors and patients will end up driving the return on investment in the decision making about what AI tools do we invest in and continue to scale, and which ones are just sort of, they sound nice, they make great promises, and they aren't really delivering anything. I think in order to do that, I always sort of advocate for more grounding on the nursing voice and the patient voice, so that we can understand where the needs are and make sure those needs are being met.
great. Yeah, thank you. I think they're all good suggestions. And I guess with agentic AI on the scene, I suppose it's endless ways you could apply AI, but I agree
Yeah,
they should only be really utilized where they can make the most benefit, because there is
absolutely.
there isn't an economic and an environmental impact from AI that we need to keep an eye on. Um,
Absolutely.
Great. Well, thanks so much for your presentation, Meg. It was lovely to see what you're doing, and it'd be great to check back in maybe in a year or two and see how it's progressing.
I would love that. I'd love to come back anytime.
Great. Thank you so much.
Thank you.